putting this onto your network. I'm very pleased to welcome Dr. Jorma Virtanen, who will be presenting today. So I've had the pleasure of working with Dr. Virtanen remotely for a few years with our Early Childhood Caries Advocacy Group, but it's also been terrific to have him actually spending time here in Winnipeg the last few months. So Dr. Virtanen is a professor of dentistry at the Faculty of Medicine, University of Bergen in Norway, and adjunct professor of public health in Finland. He is currently on a sabbatical research leave here at the University of Manitoba, spending time in our lab at the Children's Hospital Research Institute of Manitoba. And we've been delighted he's been able to even travel with us on some of our field visits to Indigenous communities. His research interests are within several health research areas, specifically health behavior, health promotion, health services research, epidemiology, prevention of disease, oral health research, and public health. And he has approximately 240 scientific publications in these fields. So we're very thrilled that he actually wanted to come and spend time with our lab this past spring. In addition to his academic duties, Dr. Virtanen serves as editorial board member of several international scientific journals, including Acta Odontologica, Scandinavica, BMC Oral Health, Caspian Journal of Social Medicine, Frontiers in Oral Health, and Journal of Education and Evaluation for Health Professions. So without further ado, I will turn it over to Dr. Virtanen and welcome to give us your presentation today. Thank you.
Thank you. Thank you for the invitation. And before I go to the topic, I want to thank for this possibility for the invitation by Dr. Schroth to visit here in Winnipeg and in Canada, and all the colleagues here in the laboratory. I thank for all your kindness and help during my stay here. I've been 3 months here now, and it's been a pleasure for me to be here. I will try to share the presentation now. Can you see and hear me well? So the topic is health behaviors of mothers of infants, and from the Nordic perspective. I come from the Nordic countries and have a quite wide experience of the healthcare systems in this part of Europe, northern part, and this is something we have gone through. I have no commercial ties. So the content of this presentation is, firstly, I will present the Nordic healthcare system, which is very different, what you have here. And then the second presentation is about the dental care for children in the Nordic countries. Then we will go on to the background of a study, which I will present in more detail, and then some research findings from that study, and maybe some other studies, and then some discussion. And I would be very pleased to have discussion also now today. So if you have any questions, comments, criticism, anything, all that is welcome. And even during the presentation, you can write in the chat box. So the aims are to give you an idea of the Nordic welfare model, and then our dental care system, and then give some insight to health behaviors of mothers, but mainly to mothers in our region, since there are certain differences. Special focus will be on sugar, and then from the Nordic perspective. And this is the Scandinavian peninsula and Nordic countries, 5 countries. Iceland is here on the top of the map. Actually, it is quite far into Atlantic, but 5 countries form the Nordic how would I say, community. And personally, I come from my hometown is here, Helsinki, here in the south, and this is the Baltic Sea. And then currently, I've been working the last years at the University of Bergen here on the western coast of Norway. Some words about the Nordic welfare model. We have quite a few healthcare systems in Europe, and here I have at least 5 those which we are aware of. The Bavarian model, which is typical in the UK. Then we have the Bismarckian, which is the model in the Central Europe, German-speaking countries. Then we have the Nordic model. In the Southern European countries, Mediterranean countries, we have a certain system, and the Eastern European countries, I don't know if we can say that it's a model, but since the Soviet collapsed, they have had a huge change in their healthcare provision. All the Eastern European countries have changed the way how to serve the population when it comes to healthcare. The Nordic countries have a similar historical and cultural background. Common labor market, free education, for instance, and strongly subsidized healthcare. We are members of the Nordic Council, but after European Union, the role for the Nordic Council has diminished, and now the situation is a little bit strange. For instance, Denmark, Sweden, and Finland are members of European Union, but Norway is not. All countries belong to the Schengen area, so we have common traveling rules. Euro currency is very special. Of the countries, Finland uses euro, but Sweden, Norway, and Denmark have their crowns. All the countries are members of NATO now, especially now during the last 2 years. There's been lots of discussion, and Sweden and Finland have joined NATO now during this period. What is typical for the Nordic welfare model? There's a high degree of government involvement, widespread availability, and tax financing. And health services are mostly free or strongly subsidized for all. And this doesn't mean the citizens or people living in the country have the possibility to use the services with same conditions. The services are publicly arranged, and we don't have very many private hospitals, or we have, of course, the private sector, but the public sector is considerable. When it comes to children, we have all kinds of... Yes. The services are universal and available at low or no payment at the time of use for all children living in the country. The preventive approach is typical for the Nordic healthcare system, and especially for children. This has lasted for decades, and it's a comprehensive system, and almost all children attend these services, and I will say a little bit more about those later in this presentation. When it comes to oral healthcare provision, what is significant is the public funding. A large number of dentists work in the public sector. And for instance, in Denmark, Finland, Norway, and Sweden, the community-based dental service employs up to 50-55% of all dentists. This varies a little bit between the countries, but it is a considerable sector in our case. And we provide free dental care for all children under the age of 19. And today, since the results are very good, we have good oral health among children nowadays. So this age limit has been expanded so that certain countries, certain areas have also young adults in this category, so they get free services. And free dental care for children and adolescents has lasted for decades. It started a little bit in different time periods in different countries, but from the 50s, 60s, and 70s, we have had it, so 50 years already. We use widely dental auxiliaries. The number of dentists and hygienists is high in relation to the number of people living in the country. And we have systematic care for children and young students and school children. Traditionally, we have had annual checkups, and only lately, during the last years, we have gone towards the individual checkup intervals, since a large proportion of the children are healthy. They have healthy teeth, so there's no need for annual checkups, but it can be up to 2 years, the individual checkup interval. Some words about the preventive approach. The countries have a little bit different profile, but for instance, fluoride rinses was very common in my country in the 70s. All children, we had nurses who went to schools, and the whole class rinsed with fluoride rinse their teeth. And after that, we started with fluoride gels. Nowadays, it's more varnishes, but we use lots of sealants. We have xylitol and many other preventive measures are taken. The coverage is high, so it can be up to 95% of children participate in this service. And for example, in Norway, we have a clinic at the institute, which is part of the healthcare system. And if a child doesn't come to the checkup, annual checkup, the family will be noted, and after 3 absentees, the case goes to the social workers. So there's high control about concerning the dental care and follow-up of the children in the system. Then, if we go forward, anyone recognize this gentleman? If your mic is muted, you can write it in the chat box if you have. No one? This is Professor Aubrey Shyam from London, and he was a very famous epidemiologist in the field of oral health research, a very known person, and his research areas were, for instance, diet, smoking, and social determinants of oral health. And I have picked here two articles published in The Lancet, which are very frequently cited even today. Is there a scientific basis for 6 monthly dental examinations? And when he wrote this article in the 70s, he was not very popular among the dental society. At that time in the UK, it was common to have 6 monthly dental examinations. Then the second article, which is close to our topic today, Sugars and Dental Decay, is a very known article for many who are doing research in this field. And he continued research among use of, in the field of sugar use in children and also adults, and we will come back to his studies later on. Some background about use of sugar. The consumption of added sugar around the world has increased dramatically over the past at least 3 decades. It depends a little bit on the continent. The current intake of added sugars in both developed and developing countries is markedly higher than what WHO recommends, which is 10% of daily total energy. The first recommendation came already in 1989, and they have continued with the same policy and recommendation later on. There are numerous other recommendations concerning use of sugary products. Many associations and countries have their own. And then it's good to remember that for children, this percentage is naturally lower. More background, many general diseases, cardiovascular diseases, diabetes, obesity, share same risk factors. And today, children and young people are experiencing lots of weight-related chronic diseases around the globe. And as a consequence, they suffer from depression, poor self-esteem, and quality of life issues. Globally, when it comes to oral health, it is estimated that 2 billion people suffer from dental caries, and 500 million of children have caries on primary teeth. And basically, we can say that the higher the sugar consumption, the higher the dental caries increment. And when it comes to health behaviors, family has the primary responsibility and role when it comes to this area. Then I will go on to mother's health behavior. Mothers play a vital role in raising the youngest children. And for instance, feeding practices, formula use, using food as a reward, etc., are important factors contributing to sugar consumption in children. And when it comes to sugar-sweetened beverages, that is the #1 source of added sugars in diet, representing almost half of all added sugars consumed. So SSP is very central when it comes to sugar consumption. And naturally, the use of these beverages is associated with several adverse health outcomes. There are lots of this is a review study, the Mazzarello case study, but there are lots of evidence for that. And mothers' own health behavior, own toothbrushing and preventive behavior are associated with ECC. We have studies, and here I have a couple of recent studies which show this fact. I will not talk more about mothers' health behavior, but maybe later on we can discuss that. Something else about this background, we know that eating habits, obesity, and socioeconomic status are related to toothbrushing. For instance, eating breakfast regularly or irregularly is a predictor of, for instance, less than twice daily toothbrushing among school children. And then physically active children had better toothbrushing habits than less active adolescents in this study, which was published in the European Journal of Public Health. Okay, we will go on now to the main topic. I will just mention here, there's a question, do we use SDF as secondary prevention tool? Yes, we use, but I don't have information about the extent of the use today, but we use it. So this study is published in the Nordic Journal, very old journal, and the topic was frequent consumption of sugar-sweetened beverages and sweets, and in relation to the age of the child. Some background for this study. We have a statewide network of maternity and child welfare clinics, and this network was built in the 1920s, so 100 years ago already. And the services include health checkups, vaccinations, personal counseling for all children free of charge and all families. And the attendance rate is close to 100%. The parents and the mothers take part in this program. And children are scheduled for an average of 3 visits per year, but during the first year, they come almost every month to the welfare center. Collaboration with the dental services is nowadays mandatory. Earlier it was recommended, it was common. Today it is in the law that the dental unit, dental service unit or health center should collaborate with health nurses, and especially the dental hygienists are involved in this widely in the current situation. And the aim for the study was to investigate the habitual consumption of SSPs and sweets in relation to mothers' behaviors and practices with their infants, young children. And the children were under 2 years old. This was part of a comprehensive study in Finland targeting mothers attending these welfare clinics. And we had 2 middle-sized towns, about 50,000 inhabitants, similar socioeconomic and ethnic background. The good thing in our country is that it's very homogeneous, so we don't have many ethnic groups there, with regard to research. So from the research perspective, it is an advantage. So the population is homogeneous, and especially these towns were that type of, not the capital, they were in the middle income group in the country. We had questionnaires which assessed the mother's knowledge, attitudes, and behavior related to oral health, and the health nurses, when the mothers came to the centers, distributed these survey tools and then followed that they filled it during the visit, and we collected the paper forms immediately then afterwards. We asked about child's health-related behaviors, consumption of sugary drinks and sweets, toothbrushing, and so forth. And then, for instance, these beverages, different types were asked separately, and then candies, chocolate, cookies, and all that with the Likert scale. And then we calculate the sum scores for consumption of sugary products, and then took into account the mother's background, age, and education, and also their consumption of sweets, toothbrushing, and smoking, for instance. And one thing to note here is that the group without specific education, just the basic education, is very small in our country. So people are quite educated, and this causes some problems when we compare our results with other countries, because we don't have that group, or it is very small. It's difficult to get a representative analysis for that. Here's some details about the analysis, statistical methods, and we use the standard type of testing and regression models, and I will show you some results and diagrams here next. Children who were under 6 months, less than half a year old, almost half of them received sugar-sweetened beverages. And this use gradually increased by age, so that when the children were closer to 2 years, all of them received sugar-sweetened beverages, at least sometimes, and more than half frequently. Fewer than half of the mothers gave sweets to their children between the ages of 10 to 15 months when they were about 1 year old, but then 92% at the age of 2 years. And these numbers were a surprise for us. This is the same as a figure, and you can see the SSB is the beverages, and then toothbrushing is the blue line here, and this is the use of sweet products, which starts at about age 1 year. So this time range was up to 24 months. So you can see that almost 60% at the age of 2 years used sugar-sweetened beverages, and then sweets were between 90 and 100%. Okay, we went through this one, and we can say that the intensity scores of sugary products increased by age, especially after the first year. These are the intensity scores which we calculated, and you can see clearly that from 13 to 15 months it goes up, and I don't have any doubt that this trend continues then after 2 years. Further on, regarding the results, children's twice-a-day toothbrushing increased from 14 to 33%. This was and we have the recommendation that they should start when the first teeth erupt. So that will be about when the child is about 6 months old. There was a correlation between the consumption of sugar-sweetened products and then toothbrushing frequency and child's age. And the regression model showed that the age of the child was the strongest predictor for consumption of these sugary products. And then when it comes to the mother's behaviors, the findings were a surprise to us. So that, for instance, smoking was negatively related to use of sugary products, and the other mother's behaviors were not significant in the way we expected from the beginning when we planned this study. So habitual consumption of sugar-sweetened products among Finnish children seems to begin very early. And I don't have any doubt that this is the case in other countries too. We don't have very many studies similar, but there's, for instance, one study our colleague from the United States has done a similar study, and the findings are very, very similar. At least half of the mothers gave sugar-sweetened beverages to their children on a weekly basis from the age of 1 year. And almost all gave them sweets from the age of 16 months. And as I said, unexpectedly, the mother-related behaviors were not associated with the child's use of sugary products in the way we expected, and our hypothesis was. But for instance, when it comes to the smoking mothers, we know that people who smoke, they tend to use less sugary products, and instead they smoke. They don't have maybe the same taste or sweet because of smoking, and this might be some kind of benefit for the child, that they don't use sugary products themselves, so maybe the children don't get as much sugary products as the other children. So something positive related to that. So the reason for unfavorable habits among these mothers, what we had in this study, is unknown. It might be attitudes. We studied also the attitudes, but it was unclear. It's a complicated field, and this figure is from the same data set. It's another study where we studied the bacterial transmission from mother to child. And we have, for instance, spoon sharing, kissing on the lips, toothbrushing, smoking, age of the mother, and so on in this study. And this is actually a three-dimensional figure. So there's a very complicated field, what has impact on, for instance, toothbrushing or use of sugar for the children. So I will not go on to this study because it's a little bit different field, but we can discuss a little bit the findings of this study. When it comes to use of sugar, so it is evident that something should be done. It's out of control now, all over the world. And the surprising thing is that the developing countries have the same problem. We have overweight children in developing countries, even if the children there have problems to get all all nutrition they need. As a public health scientist, we feel that public actions are needed. A good thing is that the common risk factor approach is very suitable in this case. This is an excellent area for us working in oral healthcare, since the other healthcare providers share same interest. So we have great opportunity to work together, and that is absolutely needed if we want to get results. The downstream treatment that we fill the carious lesions in the mouth, in the teeth of these children and adolescents, and then adults and older people, it doesn't work. So that we can, when it comes to this challenge, that approach should not be on the top of the list. Aubrey Cheyenne presented in a British Dental Journal already in 1991 an article which was called "Free Sugar Consumption should be below 15 kilograms per person per year in industrialized countries, dental evidence." And his why he considered that WHO recommendation was evidence-based was that the dose response for sugar and caries is S-shaped. So at the levels of below 10 kilograms per person per year at the population level, the incidence of caries is acceptably low. But then when we go above the 10 kilograms or 15 kilograms, which is the WHO recommendation, the incidence increases rapidly. And then he also mentioned that if fluorides are widely available, the 15 kilograms is a suitable recommendation in the Western industrialized countries. And we, in the Western world, the fluorides are widely available. If there's no endemic fluoride in the drinking water, we have at least toothpaste, which is the amount of fluoride is very high, and we have lots of other fluoride products. We can also have artificial fluoridation in the water, which is, for instance, common in the United States. What else could be done? And I was very surprised since during my visit here, just 1 week ago, the WHO issued first ever guideline for taxing unhealthy foods. So this is a very fresh recommendation or guideline, and maybe many of you have not noticed this yet, but WHO recommended strongly that countries should tax sugar-sweetened beverages. And this is not for the dental health. This is for the pandemic, the overweight and obesity pandemic. In addition, they also had a conditional recommendation in such a way that unhealthy foods should be taxed, and then maybe subsidize healthier options at the same time. And this is possible. For instance, in the UK, they have sugar tax. I don't know how it is here in Canada, but this is a very good recommendation which you can use in your work. And here is the document. You can find it. And this policy came after a WHO European region report that unhealthy foods cause some 19 million deaths annually worldwide, and about 2.7 million deaths in the European region. And after that, the WHO reacted and then gave this guideline. Here is a graph about countries which tax sugar-sweetened beverages this year, February. And you can check to your home country or where you have ties. It is good to note that white is missing data, so Northern America has no data on this, but we have taxes in many countries for sugar-sweetened beverages. So we can say that sugar, which has been a luxury good in daily basis, the sugary drinks pose a growing risk to health in developing and developed countries. And we can talk about global epidemic or pandemic in this case when it comes to overweight and obesity, and also dental caries. For instance, Southern Africa saw the world's highest proportional increase in child and adolescent obesity, 400% per last decade. That's out of control. There's evidence that that sugar-sweetened beverages have contributed to this, and the association to especially type 2 diabetes, which also increases, and other non-communicable diseases are associated with this use. I'm not aware that caries was among the diseases, non-communicable diseases in this WHO guideline, but at least the people have been aware of that. It is not, what I noted was that it was, I couldn't find it immediately. So we can say that ultra-processed foods and sugary drinks are a key factor in the rising rates. Some numbers from Canada. I tried to look for latest data. I was not able to find, but I found something. This Obesity Canada report for Senate, and then there was an article for 2016, and also the Canadian statistics have some information about use of sugar. So in these reports, 1.6 million children in Canada are reported to be overweight or obese. We can say that 1 in 3 children are either overweight, obese, 1 in 5 are overweight, 1 in 10 are obese, and also the question of abuse has been raised in this regard. We have cases in the Nordic countries where the parents have been accused of abuse when it comes to their diet, children's diet. So we can say that this large question places responsibility on several instances. The healthcare providers, of course, industry, communities, governments, and the media. And to effectively promote health in children, we should have more studies to be able to explain for the parents and for the young mothers about, for instance, sugar use and what is associated with this practice, because it varies from country to country and there are lots of cultural nuances. So we should remember that also for our own health, that we are not created to sit down with laptops and phones, that we should also actively do some exercise. Here are some references related to this study. I don't have everything here, but if someone is interested specifically in something, you can take contact to me and I will try to get an answer. This is my hometown, so if you are sometime visiting in Europe or Northern Europe, you are welcome to Helsinki and take contact. Maybe I can be your guide and take you for ice cream in the market here in front of us. Thank you.
Thanks very much, Dr. Jorma. I don't know, it's hard to compare Winnipeg to Helsinki. Sure, you're going to be sad leaving us. But if anybody has questions, there's already questions coming into the chat. If anyone wants to ask an oral question, feel free.
I can answer directly. There are some questions, for instance, about fluoridation. We have very low endemic fluoride level in our countries. So we have tried a little bit artificial fluoridation, but it didn't work. And the reason was the environmentalists who protested to have this poison in the drinking water. So we have stopped totally. We don't have salt fluoridation in our country either, but fluoride content in the toothpaste is high, 1 ppm, and since the children participate in the public dental checkup system, they get fluorides every time they visit there. So I will also answer the question regarding xylitol, which is actually invented in Finland, and we have been a strong advocate of xylitol products. And if you come to visit, you will find in the shops lots of xylitol products, and they are not so expensive. And for instance, in schools, we have had campaigns, national campaigns, where children get xylitol chewing gum in connection with the lunch they get at school. So every child gets a xylitol chewing gum in connection to their lunch. So we use that. There's also a question that what about 25% xylitol toothpaste? We discussed yesterday this topic with Dr. Schroth regarding the new study about the content of xylitol. The problem with xylitol, I have done xylitol studies myself, is that to have a clear preventive effect for dental health for a child, the child should use xylitol products frequently, and the content should be pretty high. So if you take a xylitol chewing gum once a day, it doesn't have the positive impact. It is clear that xylitol is positive for dental health, but to have a preventive impact, so one needs quite a lot of xylitol per day, so that you can show it in a trial that it has impact. So nowadays it is considered as a functional nutrition today. Okay, do we have any questions? There are lots of comments here.
I think Dr. Jorma, Dr. Virtanen, just to build on your comment on xylitol, I just wonder, because there are probably people in the audience wondering, have you had a chance to read this recent article suggesting an association between xylitol use and heart attacks?
Yes, I read some articles, but I have not studied. I'm 100% sure that our scientific community in Finland will take stand this, and I will discuss this topic. But I don't have a point of view right now. But I think that we need a little bit more studies before we can make conclusions.
Okay, great. Thank you.
Dr. Jorma, do you see the question, your thoughts on the Canadian cardiologist showing promising antibacterial cardiogenic effect?
Yes, I have, as I said, I have done xylitol studies myself, and I have participated, I have collaborated with, we have people, oral health scientists who have their whole career have been studying xylitol. So we can say generally that xylitol is positive for dental health. It has some impact on the bacterial flora and bacterial activity in the oral cavity when used regularly. But when you stop using it, the flora will come back to what it was before the regular use of xylitol products. This is shortly so it is not considered in the same category as fluoride. It is a functional nutrient considered today. Okay, anything else?
One person wanted to ask you if Greenland was part of the Nordic model for oral health care.
Greenland is autonomous, but it belongs to Denmark's kingdom. So Denmark is the main authority in Greenland.
I don't see any other questions if anybody else has.
I'm wondering, Dr. Virtanen, so you mentioned sort of the mothers who smoke, their children, there was lower chance of sugar sweetened beverages. And you mentioned that might lower risk. But I'm also sort of wondering, because there's literature out there suggesting that smoking exposure for young kids, whether it be prenatally or in the home, also carries risk. So I just didn't know, how do you reconcile that? Has your team thought of that? You know, where one, smoking may lower sugar consumption, but also could it also then have an alternative sort of negative consequence that the smoking affects children's oral health?
Thank you. This is a good point. I was maybe not so clear in my presentation. We know that the children who have smoking parents, they have in general worse dental health situation than the parents who don't smoke. My comment was only related to the use of sugar during the first 2 years, that this might be one explanation, because in this study we were not able to show the connection between mother's use of sugary products and the child's use of sugary products, and then we were not able to study carriers because these children were so young. So we know that the parents who don't care so much about their health that they would quit smoking, they don't care so much about oral health either. And this reflects on the children's dental health. So there's a clear association there, but it was just an explanation for our unanswered question in this study. I will also comment this study. This was a small study. It was representative, but for these 2 small towns, but it was a cross-sectional study. And one hint would be that if you are able to conduct a longitudinal study in this age group, that would be very valuable. We have one study ongoing right now. I'm participating in that in Turku University, where we follow the children from birth up to school age, and lots of data are collected. And for instance, we have now shown that fathers play also a certain role when it comes to children's dental health, that there's also association. Mostly we study the mother's behavior and mother's education and so forth, but fathers play a certain role also in that data set. That study is published last year in Community Dentistry and Oral Epidemiology. Yes, anything else?
I was just also wondering, sort of on the smoking front, do you suspect that it's maybe the smoking that alters taste perception, that maybe is resulting in sort of the lower intake, that the use of cigarettes, you know, just changes how people taste food? Or do you think it's something else?
Yes, I have an idea that this might be the case. On the other hand, some smokers try to cover the bad smell with sugary products. But I know, based on some kind of, how would I say, not evidence-based, but some experience, that many people who smoke, they are not so interested in sweet products. And it might have with the receptors to do in the mouth, that they don't have the same, the cigarettes or whatever tobacco products they use. It has a strong impact on the oral environment, and maybe they don't enjoy so much sweet products because of smoking.
Thank you.